So I'm going to introduce our speakers. Dr. Philip Lawson hails from Canada, where he completed his MD at the University of Calgary and his residency through McMaster University in Thunder Bay, Ontario. He is board certified in family practice and hospice and palliative medicine. Phil has practiced as a family physician for 20 years and continues as an emergency department physician and palliative medicine consultant for Littleton Regional Healthcare in Littleton, New Hampshire. He has served as a hospice medical director, chief quality officer, medical services chief, and a board member of the former New Hampshire Hospice and Palliative Care Organization. Dr. Lawson has presented locally, regionally, and nationally on issues of integrated care, pain management, palliative care, ethics, and assessment of decision-making capacity. I'm proud to say that the Alliance recently presented him with our Mary Ellen LaRoche Public Policy Award for his efforts to improve New Hampshire's laws regarding advanced directives, POLST, and end-of-life care. Lindsey Foss is a certified physician assistant who earned her master's degree in health science at Quinnipiac University in Connecticut. She's been part of both the hospice and palliative care programs at North Country Home Health and Hospice Agency in Littleton, which serves communities throughout northern New Hampshire. And her primary role has been the creation and development of a home-based palliative care program within the agency. So we are really excited to hear from both of them. Welcome, Phil and Lindsey.
Thanks, Gina. It's a real privilege to be here at this conference. It goes back many years, and I really appreciate the opportunity to speak, and particularly with Lindsey, who's a really effective and great hospice provider who I've had the privilege of working with over a number of years. Just as some specifics, feel free to pop in with some chat questions as we go along. We'll try to address those in a running fashion. Also, if we're going to address it later, it'll come up later in the talk. Hopefully we'll have a bit of time at the end. And the cases that we're presenting, there's been some minor changes to them to protect identity or in reference to the specific situation we're talking about. But these are all cases based on Lindsey and my experience. Next slide. Our goals here are that after this talk, you guys will have the tools available to, if you're not already, universally screen folks, stratify them based on their risks, support and monitor based on that risk stratification, have some backup plans if things aren't going well, and assure safe disposal. Those are really the key aspects. Next slide. We know all the good work that you guys do out in the field in regards to the care of your hospice and palliative care patients. And you all know the importance of aligning with the patient. And this is absolutely key in regards to opioid prescribing as well, that the tools, that the processes, that the strategies that you set up are set up in conjunction and to assure that patients' goals and values are met. Next slide.
One of the ways to align with our patient is utilizing the bathe technique. And this technique is a patient-centered model for teasing out and eliciting the psychosocial context of the patient's experience with their illness. And on the slide here, the 15-minute hour is a book that can be a great resource to help incorporate this useful knowledge into your practice in patient care. It has some great ideas with improving our communication and relational skills. Next slide. So the bathe technique includes background, tell me about your pain. It's an opportunity to be an active listener. Affect, how is this affecting you? Giving the patient the opportunity to name the emotion. And troubling, what troubles you most about this? This is exploring an opportunity to explore the patient's fear and their worry. Handling, how are you handling this? Allowing the patient to share with you what they feel to be their supports. And empathy, this may be challenging to you. Show them the empathy, show them that you're there for them and supportive. Next slide. So this is a case involving a 75-year-old female with metastatic breast cancer. She lived alone and she did a wonderful job managing her medications. She was identified as low risk. Then as things developed, progressed with her cancer, things became more difficult at home, and she was able to move in with her son and daughter-in-law, who were great supports. And we soon realized that as her pain increased, she had a strong reluctance to utilize the morphine. And discussion showed that she had a strong fear of addiction, which didn't quite make sense to us, wasn't clear to us until we had a further discussion with her and her son, who shared that he had an addiction to oxycodone 20 years prior and was fearful that he would give her the medication that would lead to addiction, or that he would give it to her inappropriately, as an accident, not intentionally, of course. And so once we recognized this risk, we were able to implement some things into the home that made us feel more comfortable with the increased risk and the patient and the caregiver. So we were able to provide weekly pill counts, as well as the caregiver was in agreement with recording the PRN medications. Next slide, please.
So Lindsey's case is really a really good one, and one we encounter frequently in hospice and palliative care patients. And part of this process of evaluating risk is about also evaluating underuse or restrictive use that's not consistent with ideal or best possible care. We often run into barriers to appropriate prescribing on all aspects. And another strategy, in addition to the bathe technique, comes from the serious illness conversation guide. And this is a quick training out of Stanford, a protocolized approach that can be really effective. Max Virgo, actually, and Amelia Cullinan from Dartmouth are offering this not infrequently, and I would reach out to their palliative care team at Dartmouth for the next training, a really good, very brief training on addressing serious illness, a little more targeted to primary care, but extracting one strategy from it is the 3 Ws. Aligning with the patient with I wish, moving to I worry, and following with I wonder. And we'll talk a bit more about that in the cases in the future. So next slide. Opioids and narcotics have a long and sordid history in the practice of medicine. All sorts of things across the world have been associated with opioids. The establishment of Hong Kong, coming out of the opium wars that came out of the opium dens in China, as an example, and this pendulum swing from highly restrictive use to quite loose use, and then struggles with substance use disorders and opioid use disorders, and then the move back to highly restrictive use. And it seems that very rarely in our history have we found that appropriate, balance. Next slide. If we look at prescribing in the United States, back in the 1600s, morphine was used pretty aggressively in the Civil War to manage the pain, and that led to significant challenges with addiction after. The Harrison Narcotic Act in 1914 started, highly restrictive use that moved right through to the Vietnam War, and then struggles with significant heroin use disorders after Vietnam led to the opiophobia that existed during my training. I've practiced as an emergency room physician throughout my career, and when I started practice, you basically didn't get any opioid unless you had a bone sticking out entirely. We gave almost none in emergency medicine, and required triplicate prescriptions at that time, one going to the government, one to the pharmacy and keeping one at the time. So highly restrictive use and untold suffering that then led to the studies like the support trial that showed tremendously unaddressed pain in those in the intensive care unit and those near the end of life. That led to much looser prescribing and pushes, heavily supported by Purdue and other pharmaceutical industries for widespread prescribing in primary care for non-malignant pain, which definitively contributed to our present issue. About 70,000 opioid overdose deaths in 2020. Next slide. And we can see, the pattern with the present opioid epidemic of that over the early 2000s, increased prescribing with that purple line, then restrictions around 2010, and translation to heroin overdose deaths with the restriction in the prescribed opioids, and then the manufacturing of cheap synthetic fentanyl. Next slide. So next case is a really common one. And this is our COPD, the typical emphysematous, very cachectic person with this particular woman who's had frequent admissions to hospital and numerous ER visits on tons of medications, lives alone, severe anxiety, terrified of opioids because her son had died of a fentanyl overdose. This is a situation where low-dose morphine is tremendously underutilized and can be really, really effective in the management of acute shortness of breath crises. People with severe emphysema get a mild exacerbation, they get really anxious, they start breathing really ineffectively, shallowly, just moving dead space, not effective respirations. And adding morphine in the regimen with its physiologic effects of preload and afterload reduction and its calming effects can lead to much better respiratory dynamics and the ability to effectively stave off or blunt a exacerbation or crisis, and can be very effective part of a home management plan. And in this case, it took a lot of challenge. Next slide. This patient had multiple ED visits, and I felt like a little bit I was banging my head against the wall, trying to get her to accept or to try even low dose, a very low dose opioid. And finally, I pulled the 3 W's out of my hat. Next slide, and started to work with her, using that, alignment with the I wish statements. I wish you won't experience, I wish you wouldn't experience more breathlessness in the future, and I would hope that we wouldn't need to use these medications, but I really worry that, based on what's happened, this is going to come back, and the tools that you have, the nebulizer, the oxygen, the prednisone, it's just not going to cut it, and I wonder about just, letting us, while you're here, give us a little try at it. And it was really amazing how effective for her that was, to getting her to agree to try in the hospital setting, very low dose morphine, initially short acting, and then moving to a longer acting low dose with a PRN, very low dose. And we were able to markedly reduce her emergency room visits with this approach. So that was really effective. Next slide.
And so that 3 W's approach I find to be a really wonderful way to be gentle and supportive tool when communicating with patients. And as we move into stratifying the risk of patients, when we're determining what level they are, whether it's low risk, some risk, or higher risk, there is the rare occurrence of criminal behavior, which we hope isn't the case, and as I said, is rare, but we do need to treat that legally with appropriate legal reporting and utilize the Department of Elderly and Adult Services. And as we look at the other levels of risk, that will determine our follow-up and our level of monitoring and support of the patient in their particular situation. Next slide. So this is a busy slide, a lot of information here, and you should be able to find this in your handout. And it's a reference for us to utilize as we're determining the risk of each patient and seeing where they fall under each category, little, some, or higher risk. Next slide.
There are a number of validated tools that are out there, but unfortunately, none of these tools have been validated in hospice or palliative care populations. The opioid risk tool is a commonly used, very simple risk based on evidence-based, risk factors. Next slide. And the SOAP-R, the revised SOAP tool, is a really effective behavioral emotional evaluation tool. These are complementary tools. They evaluate different things. They can be looked at, they can be incorporated, but in hospice and palliative care populations, they haven't been validated. And my particular experience is that actually they're not that effective or helpful. Next slide. So a group of us developed a tool that's really a modified ORT for hospice and palliative care populations in 2014 that I've used relatively effectively. And it's really simple. It's really 4 elements. The first element, the issue of fears and worries around opioids, or if you use the word narcotics, some people understand that better, and any strong medications for the patient or their caregiver. And that addresses the concerns about underuse as well, about restrictive use that may not be appropriate. Personal histories of substance use disorders are really important, including the specifics, like which substances and when and how long in remission or not. A family history is particularly important because this, in hospice becomes a significant potential risk. Is a family member, a friend, someone else who's participating in care having unrestricted access can trigger them suffering or relapsing, which could be us causing another problem, really. And then finally, the mental health history, particularly in relation to trauma. And for our veterans population, this is really an important area as well, because controlled substances have additional risks in trauma populations. Next slide.
And so as Phil laid out so nicely there with the 4-step process, as we go into what risks or how those risks might be stratified, some examples of low risk might include someone with no risk factors, or someone with a present or past nicotine or a controlled alcohol or marijuana use. Also, low risk would be controlled mental health disorder. Some examples of moderate risk might include past history of themselves or a family member with a substance use disorder, but with no other risk factors present. Also, moderate risk might include an isolated active alcohol use disorder, or an active uncontrolled issue with mental health or trauma. And then as we're moving into a higher risk situation, this might be a patient with an active substance use disorder in themselves or in a family member or caregiver. High risk may also be a past personal, family, or caregiver history of substance abuse, in addition to a significant mental health or trauma history. Next slide. And again, another busy slide with lots of information, and you should be able to find this in your handout. And it helps give us some guidelines on how we can respond based on a patient's risk. And these minor interventions can reduce the risk of this situation, sometimes pretty quickly. So it's nice to know what options we have. Sometimes we need to just scratch the surface with what resources there are, and sometimes we need to dive a bit deeper. But these interventions are really the supportive tools that we have, not a rigid pathway. The supportive tools that we can utilize based on this patient's individual situation. Next slide. So in this case is about a 73-year-old gentleman with lung cancer that metastasized to the liver, resulting in recurrent ascites and requiring an indwelling peritoneal catheter for drainage 1 to 2 times weekly. He lived with his wife and managed his own medications, occasionally forgetting to take his medications, but no concerns, was considered to be low risk when he initially came on to hospice. Then he developed pain, and we began morphine immediate release, and pain was well controlled. However, shortly after this was implemented, his adult daughter moved into the home, and after that occurred, we noticed that the pain control decreased, and we had some concerns with tablets missing. Next slide. So we initially or immediately increased the frequency of our nursing visits. We were already in there pretty frequently with the peritoneal drainage, but we did increase to do pill counts, which we did with the patient. We also initiated a family meeting with all the adults. So not only the daughter moved in, but her boyfriend and her children. So it was a bit of a complicated social situation, went from simple to complicated rather quickly. And so we had this family meeting where all the adults were present and discussed the agreement, the hospice agreement that the patient had signed, we also discussed some other options that we could use to or implement in the home to help with this elevated risk. We discussed a lockbox. However, this was not possible due to the tremors that the patient had, and he was typically the one who obtained his own PRN medications, and there didn't seem to be another reliable resource in the home to be doing that. And we had discussed the agreement at length with everyone present, discussing that if this agreement isn't fulfilled on their end of the agreement, then there may be some consequences to that, including and that would be in a stepwise approach, but including restriction of the medication or unfortunately revocation of hospice. And so we did have that very frank and open discussion together. After this engagement and initiating more frequent visits and pill count, the daughter did become more helpful in his care. And there were no further issues with medications missing or lack of pain control. Next slide.
Yeah, that's a great case, Lindsey, and real good. I think the idea being, as you're looking at those available interventions, which we borrowed from the substance use literature and substance use disorder clinics, in the hospice setting, it's really customizing those like you described. This was a really very recent, just about 10 days ago, palliative care consultation in the inpatient setting. A real challenging situation of a fellow who suffered horrible PTSD, severe traumatic brain injury, had been disabled for 3 to 4 decades, relied on his spouse, and also had a comorbid serious rheumatologic condition and tons of pain, had been on huge doses of opioids for decades, as well as benzos, had 28 medications, was basically on everything, managed through multiple pain clinics, been discharged for aberrant use from multiple pain clinics. Dartmouth wouldn't see him, UVM wouldn't see him, Concord wouldn't see him. Tough situation. And he unfortunately was admitted to our hospital with a tibial plateau fracture with no history of what happened. He said it just happened spontaneously and had presumed to probably have been there for a week to 2 weeks, before he came into the emergency department. And at the time he was withdrawing actively. Next slide. He had been, taking between 20 and 40 milligrams of oxycodone short acting every 3 hours, in addition to the long acting that he had had previously, but also run out of. He was angry. He was angry with the medical system. I was consulted because he was frequently stating he wanted his life to end. His old prescriber had lost his DEA based on inappropriate monitoring and risk mitigation. And his new primary care prescriber was restricted to a maximum of 100 milligrams per 24 hours per clinic policy. So this guy was in a whole lot of challenge. And he came in with just horrible uncontrolled pain and opioid withdrawal. I was consulted on day 3. So he had been managed with intravenous hydromorphone in addition to his regular short-acting oxycodone. His pain control was inadequate, but certainly much better. And his withdrawal had been treated with his replacement opioids, but he was getting about 300 milligrams per 24 hours equivalent. So where do we go from here? How do we discharge him? And, what do we do? This was really, really difficult. His history had already run through multiple backup plans in the past. And we were able to set him up with a pain clinic and discussed the case with them and decided we would try a Suboxone induction in hospital. and went ahead with that very successfully. He actually hadn't had such good pain control in ages, and was discharged doing really well, functioning really well with good pain control, with buy-in from his spouse, and assured follow-up within 3 to 4 days after inducing him on Suboxone. So that was a real effective pain management plan. Kathleen Broglio at Dartmouth has some good experience with this, and it's something to keep in the back pocket in these really, really challenging situations. Next slide. So in Lindsey's case, she referred to the agreement that is part of the initiation of care for most hospice patients, and really important to make sure that there's a checklist of things that you cover around hospice, around care, but also around the role of controlled medications, and multiple different important components of making sure people understand that these can be really effective, but also risky medications, and that the team is responsible for making sure that they're part of a best possible care plan. And finally, the agreement can assure and is a stipulated part of the DEA's requirement for hospice participation in safe disposal. Next slide. So if the initial plan's not working, there's a lot of reasons why that might be the case. Lack of effectiveness. This was the case of this, vet who was struggling so much. Lack of access, again, part of his issue. The cases that Lindsey referred to, where the caregiver was fearful to administer or the patient fearful to take. There are a subset of patients who just don't respond to opioids, particularly in situations of neuropathic or bone pain. Opioids can be really ineffective, and a subset of patients just don't respond. As a personal example, my mother had horrible osteoporosis and osteoarthritis in her last month of life with compression fractures, and her doc rotated her through pretty much all the available opioids. She just didn't respond and had only side effects. It just didn't work. And there is maybe up to 25% of people where that's the case. Frequent aberrant use or frequent, challenges that don't respond to simple interventions. And then obviously objective evidence of diversion when addressing that can't work. Next slide.
So when that initial plan isn't working, our backup plan can include a behavioral approach and really digging into the patient's current situation and how we can make adjustments there. Important education, reviewing the education with the patient and their caregivers, different open communication in different ways. Maybe there's a sit-down conversation. Maybe we're having individual communication at times with just the patient or just the caregiver, and how we can best be of support. Adjusting the risk status and supportive tools. So if something's not working, there's, as we saw in the charts, there's lots of options to consider, lots of tools to utilize, and seeing maybe this tool would be a better fit in this situation. Sometimes a different caregiver can be a better choice if there's a caregiver who's reluctant to give the medication, or a caregiver who we're concerned might misuse the medication. There might be someone else we could consider to fill that role. And also utilizing scheduled medications rather than PRN medications can sometimes be of a help, especially I find, especially in situations where the patient doesn't communicate their pain that well. We're not controlling their pain, and we can see that in their grimace, in the grimace on their face, but they're not communicating that with us. So sometimes increasing the schedule can be helpful rather than relying on those PRN medications. And sometimes the caregiver, the patient might be reluctant to give it themselves, but they feel more comfortable with a caregiver doing that. So implementing that plan can be helpful. Next slide.
And there are numerous pharmacological strategies when the initial plan isn't working. And each of these strategies, really is a talk unto themselves, but opioid rotation can be really effective, changing the primary opioid. I'd urge you against what often happens in hospice and palliative care, which is sort of the opioid add-on issue. That just leads to widespread tolerance. Whereas if you utilize rotation instead, you can make use of the incomplete cross tolerance. And that can be a real effective strategy. Parenteral pumps, transdermal delivery systems that can be assured or applied by the hospice nurse. Methadone's a great drug, but a dangerous drug. So you need to know what you're doing. It's got specific pharmacodynamic and pharmacokinetic properties that are risky, but it can be a real good drug to rotate to and really inexpensive. Suboxone, like we talked about, and then actually just trialing off opioids. It's not an infrequent situation on palliative care where actually opioids are causing more harm than benefit for a lot of issues. And I've had patients function dramatically improved by weaning them off opioids when they're just not indicated or not being used appropriately in the situation. Next slide.
In the setting of hospice and palliative care, we have the opportunity to have the ongoing visits at typically a pretty frequent intervals. And so the 4 A's can be a guideline that we utilize as we go through these visits. In the first A being analgesic effect. Is there a scale that is a good fit for the patient? Is the numeric scale effective in this particular situation? Or 2, the second A is activities of daily living and functional goals. Or in this patient's situation, are we better able to recognize he's not getting up as easily out of his chair or not able to ambulate to the bathroom anymore without help and with grimacing? Is this due to his pain? Kind of utilizing those visual cues and what we can observe might be a better result in a better outcome for that patient. The third is adverse side effects and affect. So is there something we're recognizing that is a reason to adjust what we're doing or rotate or wean the medication? And the fourth A, aberrant drug use behaviors. Do we need to adjust the risk stratification because we're noticing these behaviors? Next slide.
There are many functional scales available, and I presume most, if not all of you, are aware of the Palliative Performance Scale, an integrated and important scale for hospice and palliative care populations, or the FAST, the tool for dementia. Those are both, integrated into hospice certification criteria. The Edmonton Symptom Assessment Scale is one you may not utilize. It's pretty effective in looking at symptoms and grading symptoms and coming up with a score that can be helpful at looking at and following whether a specific management plan is working. And then, as Lindsey referred to, just looking at either a specific activity of daily living or instrumental activity of daily living and following that. Is it working or is it not? Next slide. So substance use disorders are pretty prevalent, and just a very brief review of what substance use disorders are, or the street term of addiction. This is a complex brain disorder with behavioral issues as well. The core aspect to substance use disorder is that people continue to use the substance despite the fact that it is causing harm and they are aware of that harm. That's the core sort of definitional component. And the compulsive use and craving, those C's are an effective, strategy to kind of think about substance use disorders. Studies show wide-ranging prevalences, but in certain populations, particularly trauma populations, these are extremely prevalent depending on which study and which population you're looking at. Next slide. So opioid use disorders in specific, tend to be in hospice and palliative care populations, relatively underdiagnosed and undertreated, can be triggered. You can actually cause them, patients to go out of remission if not aware. But they also, under close hospice care, can be really managed, including the use of the substances for the symptoms that they're necessary for. Next slide. We used to talk about pseudo addiction, and this is a term that I personally feel should be dropped from the lexicon. And this was really pushed by Purdue and by the pharmaceutical industry. The idea being that anybody who showed moderate or high risk behaviors was really doing that just because their pain was inadequately controlled, and that was our problem, and all we needed to do was give more opioids and that was going to fix it. that was kind of the message of 2000 to maybe 2005 or maybe late 90s. And, the reality is that this population is a wide range of issues that lead to these, poor or maladaptive behavioral issues that are problematic. And, really, it often can be due to ineffective or inappropriate medical management, but it can also be very much part of learned behaviors that just don't work and have been learned through family of origin or through struggling with a substance use disorder. And the key is obviously to, again, align with the patient, establish trust, set up strategies to support goals and values, and prescribe appropriately. Enough, and not underprescribe, but also not loosely or overprescribe. Next slide. There are lots of red flags, and these are, available in the handouts, and I won't go through them in detail. But some of the, the important thing I think to understand is the really bad ones are the really obvious ones, and focusing back on the function of the patient. How are they doing? Are they achieving their goals as best possible, their realistic goals? And is the medication plan, particularly the opioid component, assisting with that or getting in the way of that? Are there harmful or beneficial outcomes? Next slide. These, depending on what the issue is, like for obvious, definitive or objective lying to get more, or stating that you didn't receive medications that clearly are on a pharmacy review, certain medications showing up on a urine drug screen. These are all, really important and need to be openly addressed. And Lindsey had that great case of sitting down with a patient and a daughter who clearly had an issue there, but under the circumstances with close monitoring was able to control that effectively. And that in hospice patients tends to be, the result. It doesn't take a lot to get good control. Just be real careful of urine drug screens. There are a lot of false positives for certain things, particularly amphetamines, methamphetamines, whereas certain other things like cocaine are really reliable. In emergency medicine, we do use urine drug screens a lot, and they frequently turn up stuff you wouldn't expect. And this is inclusive of the hospice and palliative care patients that we see in the emergency department. So, we do find stuff that you'd be surprised of in the ER setting. And so probably using them in your really, really concerning patients makes sense. Not frequently, but to some degree. Next slide. There's a lot of reasons why you're going to run into red flags, substance use disorders, like we discussed, ineffective management, like we discussed, incompletely managed or addressed mental health issues, or just other issues like loneliness. People use opioids for reasons other than they're prescribed very commonly. And this needs to be identified and addressed to avoid issues. And then we're very rarely malingering with criminal behavior. And again, that needs to be dealt with as Lindsey described. Next slide.
So as we're recognizing these red flags, we're going to need to be addressing them. And some resources that we can utilize as we're addressing these is discussing with our team members who are also in the home providing care, in the hospice setting, or in the palliative care setting, seeing what perspectives they have, because sometimes that discussion can enlighten us to why this red flag is showing up, or maybe a way we feel approaching the red flag would be helpful. And also sometimes getting the caregiver's perspective, it really is dependent on the particular situation, but sometimes the caregiver can have some great insight as to why this is showing up, or maybe how we could be of support. Also, one strategy that we utilize that can be very helpful is bringing the discussion into IDT, the interdisciplinary team meeting, where we can present the concern that we recognize. And typically we come to this meeting with the concern, but also with a potential plan. So then we can further discuss next steps from there. And oftentimes there's additions to that plan through the team discussion. Another resource that we could consider is reaching out to providers who have provided care to this patient in the past, maybe a PCP, or in the hospice setting. I know I've reached out to a prior palliative care provider regarding a patient as a red flag with their opioid use arose, and she was a huge help in determining how to best support the patient and how to implement a plan for safe use and to lower his risk. Next slide. So the response to some of the concerning behaviors, we've covered some of these before, but some important ones include counting the controlled substances, utilizing the state prescription database and pharmacy review, concurrent history, reviewing that with the consent of the patient, utilizing urine tox screens when applicable, and an opioid challenge under observation. Next slide. So in this case is a gentleman, a 79-year-old gentleman who had throat cancer and underwent laryngectomy, chemotherapy, and radiation therapy. He was utilizing OxyContin and oxycodone for many years to address the pain related to his cancer and its treatments. He, in the past, was followed closely by his PCP, who was his prescriber, and PDMP, urine drug screening, and pill counts were all just as they should be with appropriate use of his medication. So there were no concerns in his prior history. Then just before coming on to hospice, he ran out of his oxycodone, which was unusual for him. And his wife noticed that he had an increase in his confusion and was sleeping more at home. So she was concerned. And she also said that he's very down after his recent news of no further treatment options and coming on to hospice. She was noting that he just wasn't himself. Next slide. So we initially included in our discussion depression and different treatment options, as well as encouraging that that the social worker visit our medical social worker for support. And then as we delved into the issue with running out of the oxycodone, we found that he was using it as a standing medication, taking it on a regular basis rather than just an as needed use. And in talking with the PCP who had prescribed it, that is not what his intent was. That was not what he instructed the patient to do. So there was just some confusion on the patient's end. The patient had previously been very protective of his medicine. He was in a healthy way. I say that he was managing his own medications, kept right on top of getting refills, knew when he needed to call. He did a very good job of managing it and was a bit closed at first to our help or the help of his wife, because that was part of his independence. And understandably a difficult shift for him. And so the patient was, though, open to our hospice nurse filling his pill box and doing pill counts. And he also was open to his wife helping with his as needed medications and recording those for him so that we could reference that in regards to how well his pain was controlled. And he continued on hospice for several months, and there were no further concerns of aberrant use. Next slide.
So just, following up on Lindsey's case there too, I think that a couple underutilized strategies are the issue of, trying interventions when you're really concerned or things aren't working and you're questioning what's going on. One of the great things about having hospice nursing in the home is you can actually try interventions, and sort of the trial of giving a PRN opioid in the setting and seeing what the clinical response is. There are, and I didn't use as one of these cases, but I've been in situations frequently where the patient is really participating, an elderly patient in pain is participating in the diversion to support the family member, like the child typically, who's also suffering pain, but also maybe a concurrent substance use disorder. And so some diversion is going on there. And a patient may not be getting the medication they need, and based on that sort of thing, similar to that first case that Lindsey brought up. But doing a trial right there, you can sometimes see the oversedation associated with it. when you're looking at patients on big doses, if that's a concern, you really need to have naloxone available if you're a nurse doing that in the home setting. But that's another response strategy. So moving on to disposal, and this is really an important, and in certain situations, I think under assured component of safe and effective opioid prescribing. Thankfully, now there are numerous proprietary disposal kits available. I've listed 7 there with the pictures on the slide. I am hoping that your hospices are using these. And if you aren't, I would suggest it's time. They were really expensive initially. The costs have dramatically gone down as there are numerous competitors. And for somewhere between $20 and about $50 now, depending on the volume of medicine, you can assure safe disposal with environmentally friendly strategies. And so if you're not doing it now, my opinion is that it's time to start with every patient utilizing a proprietary disposal kit. So please go back to your hospices and address that if that's not the case. Next slide. There are other strategies. None of them are as good. If we go through them, take back boxes are great, but you're relying on the patient and family to do it. And it is always inappropriate for any hospice team member or palliative care or anybody to take another patient's medication from their home. That is illegal and inappropriate and should not occur, period. So you could go with a family to a take back box and they do it under your observation, but that's pretty time intensive and pretty significant. Otherwise, the take back programs are wonderful and really good. The old strategy of kitty litter, coffee grounds, or dirt with some water in a plastic bag and then into the garbage. Yeah, that's okay. And if there's no other strategies, you can utilize that. But if you're still doing that, I really strongly urge you to move to a proprietary kit. Those strategies, there are lots of examples of people going into the garbage and fishing out the medication and getting it despite the kitty litter, coffee grounds, or dirt available. It's not an effective or assured strategy for safe disposal. And then finally, flushing. The FDA has a flush list. It's on the link on the electronic handout, or you can just Google it. And that list includes most opioids and some benzos and methylphenidate in some forms. But the DES, the Department of Environmental Services, does not recommend it due to groundwater contamination. There are pretty shocking degrees of, for instance, oral contraceptives, antibiotics, contaminating groundwater. There isn't good data on opioids or benzos. And if that's the only option, I would definitely recommend going ahead and flushing the opioids if there's nothing else. But again, proprietary methods are where you should go. Next slide. In 2014, the DEA specifically made a statement prohibiting hospices from assisting patients. This sort of led to this fear on the basis of hospices. And that's maintained in some areas for people who aren't aware that in 2018, the Support Act very specifically allowed hospices to assist patients in the disposal of medications. There are certain stipulations, which are listed in the slide in the handout, in regards to what needs to happen in order for hospices to assist patients with disposal. But those are fairly straightforward, have been addressed in our talk, and really should be part of your plan of care on hospice in any case. I'm very strongly advising that assured disposal is part of your plan of care. Next slide. So this is a real case, a 75-year-old female who's on hospice with widely metastatic breast cancer. It's interesting, just when I trained, metastatic breast cancer was like a definitive immediate hospice, referral and a 6-month prognosis or less. And now really the average duration of life for someone on hospice is many, many years. Over 10 years is not uncommon. Over 5 years is average, but this woman had been 8 years, had progressive disease, a lot of pain, was on a significant dose of opioids, got great hospice care, but there wasn't any disposal. Next slide. 4 days later, in our emergency department, her niece was transported and got CPR and naloxone and thankfully recovered, but not without some lasting side effects because of overdose that was obviously from access to those medications. That's a totally preventable, serious adverse event in a young, healthy person with a lot of life left in them. And that, you know, in my opinion, isn't appropriate and needs to be prevented. So I don't mean to leave on a nasty note, but I think I just want to emphasize the importance of safe disposal. Next slide.
So in summary, we bathe the patient and respond with the 3 W's, create that positive relationship and elicit that important information, maintain awareness of your own emotional responses, optimize behavioral, psychological, and spiritual support that's already surrounding the patient, or we may be able to implement through our palliative or hospice care, screen universally and risk stratify, including agreements, and that includes the disposal plan, and customize support and monitor based on risk. Next slide.
Having a backup plan, and hopefully we gave you lots of tools to assist in that process of mitigating and lots of ideas in regards to potential backup plans. You know, change the plan if things aren't working, side effects, underuse, or just risk is too high and maintained too high and can't be mitigated. You know, if you have frankly illegal action, a legal response is most appropriately, and then finally assure safe disposal. So you know, that summarizes our talk and hopefully gives you some good tools. I hope you have access to the handout to reference that and be able to take them back to your setting and customize them to your specific area of care, and hopefully that, you know, builds on the great work that you guys are all doing in the field and in our patients' homes. We really appreciate the opportunity to talk and appreciate you know, the value of what you guys are doing. So thank you so much.
Thank you
Yes.
very much, Phil and Lindsey, for an excellent presentation. Unfortunately, we don't have time for questions, but if folks want to put something in the chat, I think we would be able to retrieve those chat questions and maybe forward them to Phil and Lindsey so they could get back to you. And I believe that the breakouts are going to be ending and we're going to be going back to what we call center stage. So thank you for your attention.